mood disorder. Hopefully, we're going to learn in this lecture about depression and how to treat depression and what is the complication of depression. So please, if you don't hear me well, please send me a message through WhatsApp or speak here, okay? Bismillah ar-Rahman ar-Rahim. Do you hear me well? So depression is a very common psychiatric illness. It's related to something we call mood affective disorder, which is depression and bipolar. This is the two main parts of mood disorder. Today we're going to talk about depression, and next week, inshallah, or this week, we'll talk about bipolar affective disorder. So depression is a change in mood associated either with mania or severe depression. According to the old literature, the depression always comes with the stress and the grief. So something, when we lose something like a family member, money, cars, camels, whatever we lose, we're going to feel a little bit sad and depressed. Sometimes social difficulties, like when we have a stressful job or a stressful family situation, we feel depressed. But majority of the cases, depression can happen for no reason. So we don't look for a reason. That's why we don't ask the patient why you are depressed, because most of the time the depression had no reason. Maybe they have something wrong with their thinking process, like we're going to see. So their thinking process is negative. Sometimes depression can be what we call self-hate, where patients start attacking themselves. We call that in Arabic جلد الذات, or self-loathing or self-defeating behavior. So a lot of us, when we feel angry at ourselves, and that's what we call self-recrimination, and it's part of depression. Sometimes depression can be related to unconscious conflict in your brain. So you feel sad because something going on in your life that you have no control of, or some struggle related to that. Now, the problem with depression is heterogeneous. What I mean by heterogeneous means it can come in many, many ways. So because it affects all the body. So sometimes it can come with GI symptom, neurological symptom, crying, lack of sleep, overeating, not eating. So because of that, it depends on which pathways in the brain is affected. And that's why depression can vary from one individual to the other. And it always starts in the amygdala, we said, which play a major role in anxiety and depression, where the amygdala have been trained since childhood to be looking up for safety, and sometimes that looking up might put us in trouble. So most of the antidepressant work directly on the amygdala. Okay, what is the risk factor? It's very common related to stress. So anybody who had any stress, like a lot of the students might get depressed at some point in their life because of the stress of working and school requirement. It's always related to poor social support. That's why if you are a migrant from your own place to another place, you are at higher risk of depression. If you lost one of your family member early in life, that put you at depression. It's more common in women as anxiety. So anxiety and depression is twice as much common in women than in men. If you have family member of depression, and if you have some program that put in your amygdala to make it more negative. The problem with depression is really something very, very sad to tell you that money is not going to make you happy, because it's more common in people who had high income than people who had lower income. So basically, money does not make you happy and does not prevent you from depression. The problem with depression is suicide. So a lot of the patients who had depression, they either have suicidal thought or they might commit suicide. So it's very common that those patients who had depression to kill themselves. That's why always when you see any psychiatric patient, you really need to have thorough history about suicide. As we mentioned in the previous lectures,
that you have to ask any patient who come to your clinic about suicide. It has decreased in the quality of life. So sometimes when you have depression, it will affect your job, your family member, and people around you. It can happen to anyone, as we said, more common in female. Right now, there is 17 million Americans who had depression each year. And this is an old figure. I think with coronavirus, it's much, much higher than this. 8.6 of adults over 18 have at least depression. Depression is a very common cause of disability, and it has a humongous cost, $43 billion a year, cost of treating and the complication of depression and the quality of life. Depression can happen for a lot of reasons, like if you have, as we said, the lack of family support, any stress in life, any family member. Marital relation can cause depression. So if you are fighting with your spouse, that will put you at depression. We say money will not make you happy, it will make you more depressed, but also poverty can make you more depressed. So both of them can make you depressed. Early childhood trauma or abuse can put you at depression. Now, a lot of the patients who are depressed, they might medicate themselves
with alcohol and drugs. So always we need to take a good drug and alcohol history for that matter. Now, in our hospital, we see a lot of patients who have chronic illness like migraine, irritable bowel syndrome, low back pain. All of these patients will end up having severe depression. Let's look at the depressed brain. Brain, when we look at the PET scan of the brain, you can see the difference between the depression and the normal brain. See, it's like the frontal lobe here,
prefrontal cortex, is kind of like out of light.
There's nothing going on. So the brain starts getting lazy and you don't see any light in the frontal lobe. That's typical of depression. And we see in depression, the frontal lobe is really underactive where it's not able to connect with the lower part of the brain, the limbic system. So here we see the normal brain, where you see all of this light. That's mean the brain is functioning very well and active and light on. Here is the brain is only active in the limbic system here, which make the patient more emotional and more crying. So depression is really a brain disease, and that's why we really need to treat depression very early to prevent further complication. And we say that the frontal part of the brain is the logical part of the brain. So a lot of these patients, when they get depressed, they kind of like out of logic. They feel angry, they feel irritable, and they don't think very well because of that. So let's talk here about what happened in the brain in depression. So the depressed brain. First of all, there is a place you know well about from Dr.Ali lectures. It's called the hippocampus. And as Dr.Ali probably told you, that hippocampus is the place for the memory. So all of the information you're going to learn today, you're going to store in the hippocampus. And hippocampus is where is a temporary storage of information. During the night, you will transfer this information and code it in the brain. So the hippocampus play a major role in memory and control of depression. And most patients with depression have lower activities in the hippocampus. So hippocampus had been recently implicated in a lot of the complication of depression. We're going to talk about it later. Then we'll talk about our troublemaker, the amygdala. The amygdala in anxiety and depression will be hyperactive. When we said amygdala is where we store our emotional memory. So when we are emotionally crying, agitated, angry, all of that is the amygdala is working very hard, and she's becoming very sensitive, hypersensitive. And that's why when we're going to look at the treatment of depression, most of the treatment is really geared to suppress the amygdala. So the amygdala will become less hyperactive. Then we have the collateral prefrontal cortex, the thinking part of the brain. And when we are depressed, we see this part of the brain shrinking. So the cell will die in this part of the brain. And that's why it's very important to treat depression very quickly, because if we don't treat it, this part of the brain will start going bad and you don't have much activity there. And that's why cognition is a major part of depression. So
Most depressed patients, they tell you that our thinking is not great. We cannot think very well. We cannot pass exam. We cannot deal with life stress, because this part of the brain that we carry our emotion, we carry about working memory. So working memory is in the DLPFC, or the frontal lobe, while emotional memory we say in the amygdala. Then our orbitofrontal cortex, this is the
part of the brain in the frontal lobe right above your eyes, which is really involved in processing self-regulation, being calm, being happy, and controlling your agitation. That's why a lot of the time when we see patients who are very angry, that's when their orbitofrontal cortex is not able to control the amygdala, and that's what they make them angry and irritable. So this is to look at it from different point of view. This is the DLPFC, the disolateral prefrontal cortex, which is responsible for planning and working memory, and prioritizing means, should I do this or that? How I can maneuver my time to get the best out of it. So this is the role of the disolateral prefrontal cortex, DLPFC. Then we have the orbitofrontal cortex, we said, which control our impulse, make us calm, make us less angry, self-regulation, and make us connect with other people. And this part of the brain also get damaged in head injury, we said before, and in depression. So in depression, we can tell that this problem happening here if the patient kind of become angry easily, violent, unable to control his rage, shouting. This means that OFC in their brain is not functioning very well. And the frontal lobe in general is the part of the brain that control our anger and prevent us from addiction. So we see depression will affect all of these parts of the brain and make it less functional. But the main issues here is really the hippocampus. All of the study, this is what we call the Schelin study. This is very, very important study. It took place about 20 years ago, and it showed that your hippocampus here, that the green one, which is, we said, responsible for cognition and memory, and it also regulates HPA axis. So when we have high HPA axis, the one that tone it down is the hippocampus. So if you have depression and you don't treat your depression very well, so in 10 years, you're going to lose half of your size of the hippocampus. So your hippocampus will shrink in size. So when you lose your hippocampus, you kind of become less cognitively well. So you will become forgetful, you don't think very well, your process of thinking becomes slow. And also your ability to find cortisol level will be low. That's why, like when I get angry and depressed, the amygdala raises the HP axis. So the hippocampus is the one that tone it down, so lower it down. That's why if you keep getting a lot of stress and depression, your hippocampus shrink with time, because you will have no ability to decrease that cortisol increase which happen due to the stress. So that's why we said we need to treat depression aggressively, because these patients who had a lot of stress, if they kept their cortisol level high all the time, they end up with diabetes and hypertension. So this is related to the losing function of the hippocampus. And the most important things in hippocampus is really, it's part of the brain that we still make new cells. So in hippocampus, which is responsible for memory and cognition, God gave us the ability to make new cells there. And these new cells will help us in learning and memory. So we call that neurogenesis. Neurogenesis is when we make new cells in the brain. But mainly in the hippocampus, if you look at the neurogenesis, the peak neurogenesis happen in the middle of the night. So you look here is in the midnight where you see the peak neurogenesis. So if you are sleeping in the dark at 12 o'clock at night, this is the highest time where you are making new cells in your hippocampus. And that's why you always tell your patient who are depressed, you need to sleep between 10 and 12 and 2. Between 10 and 2 is the peak neurogenesis in the hippocampus. So part of the treatment when we treat depression is, I always tell my patient, you need to sleep at 10 o'clock. Why? Because between 10 and 2 is where you make a lot of new cells in the hippocampus. So whenever you see a patient come to your clinic, he said, I cannot remember well, my memory is bad. The first question I ask him, tell me what time you sleep. Oh, I sleep after Salat al-Fajr. Okay, you're not gonna get better. Why? Because between 10 and 2 is the best 4 hours of sleep where you get this neurogenesis in your hippocampus. And it has to be dark because the brain cell will not grow if there is any light. So people who sleep after Salat al-Fajr, they lose tremendous window of brain cell growth, especially in the hippocampus where the peak of neurogenesis happen. And that's why if you sleep at least 4 hours, then you're gonna be able to have a lot of new cells in the hippocampus, so you can learn and use them the next day in learning lectures and learning things in life. So again, because this is very important slide, the best 4 hours for sleep is 10 to 2. Why? Because midnight is the peak neurogenesis in the hippocampus, as you can see here. Why I need neurogenesis in the hippocampus? Because hippocampus is the part of the brain that is responsible for learning and being very good in cognition. So having these 4 hours of sleep always is good for your depressed patient. So always tell your patient, sleep between 10 and 2. Is that clear, dears? Okay. So the other part, I don't want you to mess up between hippocampus and hypothalamus. The other part of the brain really implicated in depression is called hypothalamus. And hypo means below. So hypothalamus means below the thalamus. And hypothalamus is like a group of nucleus. It's not one place. It's like Al-Qasim. There is no city named Al-Qasim. There is a group of cities in Al-Qasim province. So here hypothalamus is not one place. It's few places where you see nucleus to regulate the weight, nucleus to regulate the appetite, place to regulate sleep, place to regulate circadian rhythm, place to regulate hormone or place hormone in the brain. So hypothalamus is responsible for weight, appetite, thirst, hunger, part of sexual activities and hormone regulation, all in the hypothalamus. And usually those are severely implicated in depression. So when you are depressed, you cannot sleep. This is the hypothalamus. You cannot eat. This is the hypothalamus. Your day and night is mixed up. You sleep in the day and cannot sleep at night. This is the hypothalamus. Your cortisol level will become high and low. This is also part in the hypothalamus who control that. Your thirst, your hunger, your electrolyte imbalance, all of that is the role of the hypothalamus, and they are really messed up in the depression. The hypothalamus is the part of the brain that communicate with the higher brain and control our hunger and our temperature, sleep, and biological need. It's all in the part of the hypothalamus. So, but the feeling of depression usually starts, as we said, in the amygdala or in the subcortical region here, this green region called subcortical. That's mean below the cortex. So feeling is always, when I feel sad, feeling sad is in the cortex. But we said the trigger for feeling sad is always in the amygdala. So we are a side product of our amygdala or subcortical region. So if I see somebody, like we said in the previous lectures about Samiha, when she saw that guy who was wearing the striped tie, she felt bad. Why? Because the feeling came all the way from the amygdala, where the amygdala carry memory from that event in the past and make you feel this way. So always our feeling is related to what happened, what we store in our memory in the subcortical region, mainly the amygdala. So we are, our feeling is a product of our emotion. So when you see me angry or happy, it's something stored in my amygdala that make me feel this way, trigger that feeling. So really, then, and our feeling is not really reality, it's the emotional feeling. And that's why we always try to correct that feeling of emotion, because emotion play a very important role in our life. That's why we like somebody, we hate somebody, and we need the frontal lobe really to have control of that emotion. So always when emotion control you, you are not seeing the reality. You are seeing what your emotion wants you to see. Like when you are in love and you love somebody, and that somebody might be a horrible person, But because your amygdala like him, you're gonna like him. You don't look at the logical part of the brain. And we're gonna talk in detail about this in our next lecture of addiction, inshallah. So how we diagnose depression? We look at the patient and you see different type of feeling. Like this lady here, putting her head on the stone here, she is what we call internally preoccupied. She is having a lot of emotion in her brain. This guy here, this lady here is very anxious, so anxiety can be symptom of depression. This guy is putting his head like this and don't want to face the world. This is severe depression. This lady is having what we call fetal position. And when we do this fetal position, we are having a defense mechanism called regression. Regression is when you have severe depression that you really don't want to face the world, and you're going to go back to the earliest part of your life when you were safe. And the earliest part when you were safe in your life is when you were in your mother's womb. So your body is always trying to take you back to the unconsciously to the place or to the position where you felt safest. So we call that regression, severe regression. So when you see patients sitting in fetal position, then you need to look at it and say, wow, he had severe depression. That's why. It's like when your computer messed up, you kind of fragment it. You put it back on the original. You just, what you call it, you make it back to the original position, trying to figure out what's going on with him. And your body do the same. So when I face a lot of stress, I cannot deal with it. So what I do is I will try unconsciously to sit like this in this fetal position, hoping that if I go back to the original place where I was safest. And I try to go back there so I can feel safe. And a lot of the patients, when they feel depressed, they start crying. Crying was also a form of regression, because when you were kids and you have problems, you used to cry a lot. And that's what you call regression. Also, when you are depressed, you walk slowly. This is the basal ganglia problem. Basal ganglia is responsible for our movement. So when you walk slow and you put your head down, it's like really problem in your basal ganglia. So we use the DSM-5 criteria for depression. And as you know, DSM-5, the Diagnostic Statistical Manual 5, this is a group of symptoms put by the American Psychiatric Association as a language between physicians to make a criteria for people who are depressed. So DSM-5 state that in order for you to feel or to diagnose somebody with depression, you have to have depressed mood, feeling sad for at least 2 weeks, plus apathy. Apathy means losing interest in anything. Plus, you have 4 of these things here: fatigue, like you feel tired all the time, having no energy, or the opposite, you have severe psychomotor agitation. You feel irritable and angry. You have sleep disturbance. You either sleep good, you sleep too much, or you sleep too little. Both of them, you can be depressed. If you sleep, like a lot of the patients who are depressed, they sleep like for 10 hours, but they wake up very, very tired. And we're going to talk about it in sleep lectures. So sometimes you sleep well, but you wake up very tired. That's meaning you have enough quantity of sleep, but poor quality. So you sleep 10 hours and you wake up tired. This is bad sleep. Weight loss, either you eat a lot, like when you feel depressed, you go to the fridge and start eating. And some people will stop eating. So you either eat too much or not eat at all. You feel guilty. Your executive function means your thinking and your memory and your ability to read, all of that will be impaired. And the most important thing in depression is suicidal thoughts. So a lot of patients with depression will try to think about suicide. So always when you see any patient who are depressed, you always check about suicidality. Tell me, have you ever felt suicidal? Have you ever felt like you want to kill yourself? This is very important. So everybody use the synonymous called SIGI-CAP. S for sleep, I for interest, G for guilt, energy, E, concentration, appetite, psychomotor activities, and suicide. So it's called SIGI-CAP. And each symptom is related to one part of the brain. For sleep is in the hypothalamus. Interest is in the place in the brain called Nicholas accumbens. We're going to talk about it in detail in addiction. Guilt, rumination in the frontal lobe and in the amygdala. Energy in the basal ganglia. Concentration in the hippocampus and the DLPFC. Appetite in the hypothalamus. Psychomotor activities in the basal ganglia. And suicide is related to low serotonin level in the brain. So why suicide is very important? Because 15% of the people who are depressed end up committing suicide. That's why I always ask about suicide. However, most depressed patients usually don't come to psychiatrists and say, I am depressed. So 70% of those patients who are depressed, we never see them. They go to the primary care physician. That's why when you become a primary care physician, internist, or family physician or GI doctors, half of your patients are depressed. In fact, in primary care, 90% of the patients in primary care are depressed patients, but they package their symptom in emotion, in headache, back pain, GI pain. Why? Because it's more acceptable. Our society and even the Western society is more, they will accept you as having a tummy pain or back pain more than having a sad feeling, because still in our society, going to see a psychiatrist, that's mean you are crazy, and that's not good for your self, for your image. So all of them would rather go to the primary care physician and spend many tests and everything, because it's much acceptable in society to package all of this feeling and emotion in physical symptom. So what happened is, in depression, and this is very important slide, and I want you to really concentrate with me very well here. So we said when we are depressed, we have high emotion. Our limbic system is very active. That's why we cry easily. We just cry. We feel unable to, these emotions, when you keep them, they will hurt you. Usually the frontal lobe is underactive in depression. So that part of the brain that want to balance those feelings is not working well. And that's why we feel angry, we feel depressed. So in depression, is really, the limbic system is overactive, and the PFC was supposed to be our babysitter, the part of the brain that really communicate with the limbic system and take this emotion out, is really not active. And that's why in depressed patients, they become angry easily, or they come in physical symptom, because I'm not able to balance those information or balance those feelings. Like sometimes when you see the woman crying, most of the women cry because their husband does not listen to them. If she had a good husband who listened to her, all of these symptoms in the emotional feeling in the limbic system will be balanced by the frontal lobe. But you have to have a person who listens to you. When we see what is the most common complaint by women, two things about their husband: he doesn't help with the house, and he doesn't listen. That's why listening to people is very important, to make their frontal lobe take out that emotion in their limbic system. And that's why as a kids, they teach us to do that. Remember, as a kids, they always tell you, draw a picture, write a story. That's why they ask us to write a lot of stories. Why? Because they want us to learn how to express those feelings in the limbic system in the frontal lobe. So we feel better. Once you talk, you feel better. You balance, or you took out this emotion. When you see somebody crying, that's mean I have way too much emotion. My frontal lobe is way down, cannot deal with it. Because we carry all of this emotion of loss, stress, grief, thinking about the future, all deep in our limbic system. So when we give medication to treat depression, we kind of flip that out. So we make the limbic system less active, and we make the frontal lobe more active to balance those information. So in depression, the limbic system is overactive, the frontal lobe is underactive. So we need to balance this between the emotional part and the thinking part of the brain. We need to empower the PFC to control the limbic system and take that anxiety out. And let's start with the case. And the first case we have today is Kamal. Kamal is a man who came to the clinic with severe depression, but he come with a lot of what we call physical symptoms. So he used to come to the clinic with headache, constipation, weight loss, low energy, joint pain, high blood pressure, stomach pain. This is all we call physical symptom, and it's always related to depression. But Kamal did not go to the psychiatrist. He go to the primary care physician to treat the headache and the constipation and the migraine. But the family physician realized that this guy is depressed, but he is manifesting his depression in physical symptom. And this is probably is 90% of the primary care presentation in the clinic. All of them, or 90% of them, are really genuinely depressed, but they come with physical illness. When we look at the childhood of Kamal, let's look at the childhood. Kamal had very bad childhood in terms that his father told him that kids should not have any excitement. So during the holidays, Kamal was trying to show excitement, and the father said, no, kids does not do this. Man should be straight and should not have any emotional feeling, and he should be always what we call, jiddi, means serious all the time. So father jumped on him for showing any excitement or too much excitement during the holiday, which is against the nature of the child. The child has to do that. Then Kamal, when he was a child, got punished for his feelings. So when Kamal will show any feeling, or when I talk about feeling, the father will like scolded him, and he said, we don't cry. A young guy will not cry. A man will not cry, which is not true. Man can cry. He's going to cry. So because his father want to bring him up to be a real man, so he told him that man will not cry. So from childhood, he had learned how to show no emotion. So Kamal has miserable childhood because his father told him that crying and showing emotion is a kind of weakness, and that is not good for a man to show this. A man should not show all this feeling. So this is what Kamal grew up to be. He grew up to be what we call keep his feeling for himself. So this feeling in the limbic system were not allowed to be expressed in the frontal lobe, because I am a man. I keep my feeling inside. I don't express my feeling. So over time, Kamal learned how to keep a mask face. He will not show any excitement, any emotion. He was always like flat. That's what his father told him. He told him about man. Man should do this. And this is totally wrong. Man should show emotion, shouldn't cry, shouldn't have any feeling, because feeling is in the limbic system. You have to express that feeling. You don't want to make people emotionless. But because what happened to Kamal in the childhood, this is what happened to Kamal in the real life. Kamal got married, and 5 years later, his wife Kamala divorced him. Why did she divorce him? We asked Kamala, why you left Kamal? And Kamala said, he is uncaring and unemotional. Remember, woman does not like person who is a piece of, furniture. She like to have a man who has a feeling, to have excitement, to have love, who had, Kamal, because his father told him that he need to be flat all the time. He should not show any emotion. The wife did not like him, spent 5 years to try to change him, but she couldn't. So finally she divorced him. Kamala left. Of course, Kamal got hurt, but Kamal is deeply hurt, but he did not express any emotion. He packaged his emotion deep inside him, and this emotion manifests in physical illness. So Kamal, when Kamala left, he didn't cry, he didn't get mad, he just was flat like before. He did not see anything. He packaged his emotion in physical illness. And that's why we say when we have emotion in this red limbic system, the way should this emotion be valence is through the frontal lobe. Remember, in the old poetry in the Arabic culture that always write about how he loved his wife or fiancée and wrote poetry about it. Why? Because this feeling inside me, I express it through the frontal lobe. This is a healthy way to express those feelings. Like, remember Antara, and I will not be able, I will try to translate it for you. Antara, when he liked Abla, he used to say, وَلَقَدْ ذَكَرْتُكِ وَالرِّمَاحُ نَوَاهِلٌ مِنِّي وَبِيضُ الْهِنْدِ تَقْطُرُ مِنْ دَمِي فَوَدَدْتُ تَقْبِيلَ السُّيُوفِ لِأَنَّهَا لَمَعَتْ كَبَارِقِ فَغْرِكِ الْمُتَبَسِّمِ. So Antara was in love with Abla, and this is probably 2,000 years ago. And Antara said, when I was fighting with the sword will have a spark, and the spark of the sword reminded me of your teeth, which is sparkling all the time. So even when Antara was fighting and between death and between life and death, he was remembering the sword sparkling in the sun, reminded him of her teeth. This is a huge way of expressing your love for Abla. So that's how much he's feeling for her, and that's how the love was expressed through the frontal lobe. But with Kamal, he was not supposed to do anything like this. He was supposed to keep his feeling for himself. So when we keep our feeling to ourselves, it's ended up having a lot of, physical symptoms. So all of this, when you see patient with spastic colon, GI symptom, migraine headache, all of these patients are really helped very well in treatment of depression by teaching them how to express those feelings and to teach them how to communicate their emotion in word and in writing rather than in stomach pain and headache and migraine and asthma. All of these we call psychosomatic disease. So what is the theories of depression? There is many theories in depression. One of them is the biological theory. So biological theory said that in depression, we have lack of neurotransmitter. The main two neurotransmitter lacking is norepinephrine, serotonin, and dopamine. So 3 neurotransmitter lacking in depression: dopamine, norepinephrine, and serotonin. Serotonin is secreted from place in the brain is called raphe nucleus. Dopamine, norepinephrine in the locus coeruleus, and dopamine deep in the brain in the ventral tegmental area. We'll talk about it next time. So usually when you have stress, your serotonin will reduce. Why? Let's see, you have very stressful life. What's going to happen to your serotonin? It's going to go down. Why? Because serotonin is a neurotransmitter that makes you relax and happy. So if you are not relaxed and happy, then your body stops secreting serotonin. It's like, I always give you this example. My wife is gonna kill me, but I asked my wife, why you don't cook me this favorite food I have, let's say grape leaf, and she said, because you are never home. Home, I'm gonna cook it for to the wall. If you are not home, I'm not gonna cook it for you. And that's what happened in depression. So if you are depressed, you stop secreting serotonin. Why? Because serotonin is secreted when you are relaxed and happy and you want to sleep. But if your life is very stressful and you have a lot of stress, then you don't need the serotonin. I'm not going to give you serotonin. And lack of serotonin is the main symptom in depression. All the symptoms you see with lack of serotonin is anxiety, GI, headache, lack of sleep. All of this is related to low serotonin. That's why most of the medication to treat depression usually help in increase the serotonin. So this is what happens when you don't have enough serotonin in the synapses in the brain cells. The message from one neurons to the other will not carry through. So you see here in the left is the neurotransmitter. You have plenty of neurotransmitter here, so the message will go through. If the neurotransmitter is lacking in the synapses, then the message will disrupt it, and the message does not go through, and you feel sad and depressed. So the role of medication called SSRIs, which is like Prozac and Cipralex and Lostra, and all of these SSRIs, the role of SSRIs is to increase the serotonin in the synapses, and that's how we treat depression. So this is the what we call the SERT. The SERT is the serotonin transporter that carry the serotonin through the synapse. And in depressed patient, they might have short version of the gene serotonin. So all of us will have either the short gene or the long gene. If you have the short gene of the SERT serotonin transporter, you are at risk of developing depression. If you have the long gene, you might develop depression, but less likely. So we inherit two type of the gene from your parents. So you might have S and L, or both L or both S. It's dependent on which one you get from each parent. So if you have the short gene of CERT, you are more likely to get depressed. If you have the long version of the gene, you will not get depressed easily. Stress, as we said, is very important in depression. So that's why when we have low serotonin will cause a lot of things, not only depression. Remember, only 2% of the serotonin are in the brain, 90% are in the GI, and 8% in the platelets. So that's why depression can come in many ways. So depression, anxiety, panic attack, insomnia, irritable bowel syndrome, PMS, fibromyalgia, obesity, eating disorder, irritability, OCD, pain, all of called CRH. CRH is the corticotropic releasing hormone, or CRF, or sometimes they call it CRH. So both are the same. And because the life of the breast patient are very stressful, you see the CRH level is almost 3 times as much in depression than in control. This is here the control, normal people, and this is a depressed patient. The depressed patient had much higher level of CRH. That's why they have high cortisol level and high HbA axis and high ACTH. Let's see now move to we talk about the biological cognition in depression. Let's talk about the cognition. In the cognition, let's take the case of Christy. Christy is a real estate agent, very beautiful real estate agent, 33 years old, who present with severe depression. She said, every time I tried to sell a house, I couldn't sell the house. She started blaming herself. If I had worked better, if I negotiated better, if I had talked more persuasively, the deal would have gone through. So every time she failed in doing her job, she blamed herself. This is what we call self-loathing behavior. So this is how the patient who are depressed think. So depressed patient have what we call automatic negative thought. So every time I see something, then I'm failure. So Christy here, when she failed to sell the house, her automatic negative thought came, I'm a loser, I'm no good, I will never succeed in my life, it's all my fault. This is what you call cognitive distortion. Let's see, if you fail in exam, la samahullah, you always blame yourself. I should have studied better, I should have not watched that movie, I'm a failure, I'm no good. So this is what you call automatic negative thought, and they are very bad thought. You need to get rid of these automatic negative thought all the time. So her thinking become increasingly negative. This is typical of depressed patient. They become negative in their self-esteem. They feel bad about themselves. They blame themselves, although it's not their fault. This is Christy when she wake up in the morning. I know her skin look a little bit darker. This is without the makeup, probably. I'm just kidding. Okay, so Christy wake up in the morning. This is how her thinking will be. Okay, she start in the morning, I will mess up again. I'm a failure. There is no point in waking up. This is the negative thought that start her morning with negatively. I'm a failure. You know, it's like I will mess up again. I will have no point of. So I'm a failure, I will not succeed, I'm not good. So then these negative thoughts will cause her feeling to feel grumpy, tired, lethargic, no motivation because of this negative thought. And the behavior will be, I'll just stay in bed. I don't want to do anything. Let me stay in bed and let me do nothing. So this is what you call the cognitive behavioral distortion in these patients. Our feeling affect our thought, and our thought affect our behavior, and our behavior affect our thought. It's a vicious cycle go through every day. I'm a failure, I will feel sad, tired, I will go to bed. If I go to bed, I will feel sad again, and I will think I am more failure. So in CBT, cognitive behavioral therapy, we try to break this cognitive distortion, challenge these automatic thoughts. Tell me why you are a failure. Tell me how many times you succeed. Tell me why you don't want to get out of bed. Tell me how much you have succeeded in life in the past. So the activating event in Christina and in Christy is she couldn't sell the house. That's what we call ABC. Couldn't sell the home. B is the belief that I was incompetent, I'm unlucky. Consequences, I'm a failure. So she reached a conclusion that she's a failure based on one event that she couldn't sell the house. So this is what we call ANT. ANT is the automatic negative thought, which is very common in patients with depression. And that's why we do some treatment called CBT. Cognitive behavioral therapy is to try to get rid of these negative thought where she attack herself, she self-re-incriminate herself by attacking herself and blaming herself. This is all the role of the amygdala. So when we give her medication, we tone down the amygdala, and then we give her something we call cognitive behavioral therapy to make her think the opposite feeling or make her think the other side of the coin, to look at the full part of the glass, not the empty part of the glass. So this is the role of CBT, cognitive behavioral therapy, to clear that brain, to decrease what we call the all or nothing. So if I fail one time, I'm always a failure. If I wake up tired, that means I'm a failure. They connect things in a different way, in a wrong way. They overgeneralize, so they make one mistake and they generalize it to all of their life. So this is what we call cognitive behavioral therapy. We change that by doing this. The behavioral theory of depression reveal that it's related to failure in life or related to relation with other people. So for example, you feel depressed if you live in an environment where there is no appreciation. So you always, when you see somebody doing good, you always have to say, great job. I'm very proud of you. You are doing great, because this will bring the positive in them. Positive reinforcement is very essential to treat depression. So when I see depressed patient, I don't ask him, what's wrong with you? I ask him, tell me about what's good about you. You know, I always like, a lot of the time, I see a patient who are depressed and I give him medication. The first thing they ask me, what is the side effect? And here I jump on the patient. I told him, you always ask me about the side effect. Why you don't ask me about the benefit? And this is the role of depressed patient. They always ask you about the negative, not the positive. So I will sit with the patient. Okay, the first thing when I gave you your fluoxetine to treat your depression, you told me, what is the side effect? Okay, why didn't you ask me, what is the benefit? How this is going to help me? But because of their negative thinking, they always think about, tell me what the side effect. Well, that's not good way to deal with depression. So always look for positive reinforcement, be optimistic. We teach patients how to be optimistic. So if you live in a place where you are fighting with your spouse all the time, you're going to be depressed. If you fail in love, this is a behavior, you're going to feel depressed. If you have bad environment where nobody appreciates what you are doing, you're going to feel depressed. In fact, Freud, Freud is like the father of psychiatry. He said that there is always connection between depression and loss. So always when you lose something, you're going to become depressed. So always connect depression to a loss. Most depressed patients had lost something and they go to regression. Regression is when you go back to the early development milestone. Now here, it's very hard sometimes to differentiate between anxiety and depression. Most of the patients will have both anxiety and depression. They overlap. A lot of the symptom is common between both of them. If you are only worried, this is anxiety. But if you are worried and sleep problem, tired, concentration, this is anxiety and depression. Depressed per se is when you have suicidality, you feel severely tired, and you have low self-esteem. This is more depression. But 90% of the patient will have both anxiety and depression. So the problem is what happens when you have both anxiety and depression. This is very important. I put a star here. If you have both anxiety and depression,
that increase your risk of suicide. So you are more likely to kill yourself if you have anxiety and depression at the same time. That's why it's very important to recognize that it's really anxiety or depression or both. So majority of the patient had both anxiety and depression. But why we need to differentiate? Because the treatment is different. So if you are anxiety, then your treatment is different than depression. But we said most patients have both. So if you have both, we'll see where are you leaning to. You are like mainly depressed or mainly anxious. So you are mainly depressed with some anxiety or very anxious with some depression, because like treatment will be different. And we're gonna talk about treatment later on. So this is the difference between anxiety and depression. I put it in the two ends of the spectrum, but we said most of the patients have both anxiety and depression. Now, what is the type of depression? The type of depression, there is many types of depression. There is adjustment disorder with depression. This is pure depression, but it does not have enough time to be depressed. So less than 2 weeks, we call that adjustment. There is bipolar 1 and bipolar 2, and we're going to talk about it in the next lecture. There is postpartum depression, which depression happened to the lady after the giving birth of her baby. In the first year of giving birth, a lot of the female feel depressed. Dysthymia is like a chronic depression, not severe, but chronic, but lasts for many years. Cyclothymia, seasonal affective disorder is the depression you get in the fall or in certain season, like during winter or during the fall. And PMS is very common. And there is what we call depression with psychiatric feature, is the depression that happen and you start hearing voices or feeling paranoid. So we call that depression with psychiatric feature. Depression with psychiatric feature is treated best with ECT, electric convulsive therapy, not medication. So the best treatment for depression with psychiatric feature is ECT. And we said postpartum depression, we talked about it before. So this is postpartum depression, is the depression that happened in the first year after giving her birth. You can see that the lady is waking up all night, taking care of her baby, and the man is sleeping and dreaming. So that's typical of some men, they don't care much. So anyway, the woman might experience this if she had low support system, if she had problem in her hormones. Most of women have what we call postpartum blue. Postpartum blue is not real depression, it's a symptom of sadness, but it's not dangerous. It happened to most women. 60% will have this. But postpartum depression is the real depression, which happened to 1 in 10 women. So it's like 10%. It's more severe form, and this need to be treated aggressively. We said the consequences of depression, the main issues in depression is really suicide, but a lot of the patient, even when they are depressed, they lose a lot of things. For example, if you are depressed, it's going to affect your job. So when you are a physician and you are depressed, you're not going to accomplish much. So we call that DALI. DALI is the global burden of the disease. So you are working in your job, but you are not doing well in your job. You are not functioning well in your job. You are not as productive because of that depression. So we call that DALI and years. Treatment for depression will wait for the next session, inshallah, with the bipolar, and we'll talk about the treatment. I will leave the 5 minutes for question. If you have any question, let me know now, and thank you very much for attending the lectures. The floor is open for question.
Stories help patients with depression because it makes you relate to other people. Whenever you relate to other people, you feel less anxious, less depressed. So always when you do stories, it's help a lot because you feel there's someone else have the same problem. That's why we cry when a song talk about our feeling, because we like to connect our limbic system with the limbic system of other people. That's why some express your feeling. It's feel like what's happened to you. That's why most of the song is about love and setback in life and emotional feeling, because we connect our feeling with their feeling. We like when we connect our feeling with other people's feeling. When we write something, it will be able to balance those feelings. So when I tell you to write about your feeling, I'm helping you express the feeling inside your limbic system, take it to the frontal lobe. So make it from unconscious to the conscious level. That make you help a lot. So the way we treat depression is to psychotherapy is when you let the patient vent and express those feelings. When you express those feelings, you feel much, much better. You are taking out the limbic system feeling to the frontal lobe feeling. The frontal lobe is the logical part of the brain. The limbic system is illogical. So you cannot do anything with illogical. You can do things with frontal lobe, the logical part of the brain. Just only the slide that I talk about is with you. When you see the word thank you, that means is not, I keep it just for your own reference. The rest is for your own reference, not for exam. Only the slide I gave you is the one that come question in the exam. So just read them. I put the rest of the slide just to clarify something if you need any help. But I'm always ready. If you have any question, please send me on WhatsApp. So the 180 slide is not just for you, it's just for you to clarify something. So they have explanation about the lectures. If you need them, just do them, but don't study them per se. Maybe keep them for future reference because they are very valuable. Okay, any more question? Thank you very much for having me, and hopefully to see you Wednesday in